Good afternoon, everybody. Um, I'd like to begin by acknowledging that we're gathered today virtually on the traditional, ancestral, and unceded territory of the Musqueam people. And as a School of Nursing, we are grateful to live, learn, work, and of course, research on these lands. Well, my name is Ash, and I'm an Associate Professor of Teaching in the School of Nursing, and I'm delighted to welcome you to today's Nursing Rounds on behalf of the Scholarship of Teaching and Research Committee. Today's Nursing Rounds focuses on promoting women's health and well-being, and we're privileged to have two outstanding researchers with us, each advancing women-driven, evidence-informed approaches to care. So we're going to hear first from Dr. Saima Hirani, whose work in mental health promotion highlights the power of co-design and community empowerment. And Saima will share insights from a collaborative project to create a toolkit that supports maternal mental health. And then we'll hear from Dr. Ruby Dev, a global women's health researcher whose work addresses the urgent need for better cardiovascular risk assessment in postpartum women, an area that is often overlooked. So please join me in warmly welcoming our presenters, and I'll hand over to Dr. Hirani.
Thank you so much, Ash, and good afternoon, everyone. And thank you so much for attending today's session. It's so good to see some of the familiar faces and names and people that we have worked with. So I'm grateful for you all to joining the session today. So just give me a second. I'll share my screen with you. I hope you can see my screen and it's a slideshow mode. Perfect. Thanks, Colleen. Hi. All right. So thanks, Ash, for the land acknowledgement and our introductions. I'm honored to be joined by my co-presenter, Dr. Ruby Dev, today. And together we will be sharing two diverse research examples from our research work that support the research agenda to promote women's health and well-being. Yeah. All right. And I would request everyone to take a moment to please acknowledge that land you are coming from. All right. So in today's presentation, we will explore the critical nuances of women's health, examine key challenges women face, and highlight the call to action. I'll be briefly talking about this overview and then share one of the examples from my work and then hand it over to Ruby to continue the presentation. As I mentioned earlier, women's health is a very complex construct and a very broad topic. So the diverse examples that we too will be sharing, I hope will contribute to further understanding the women's health and well-being aura that we have that our research work is aiming to address. So let's start by broadening our understanding of what we mean by women's health. When we talk about women's health and well-being, it is important to recognize that women's health is not only about reproductive health. That was one of the considerations earlier in people's understanding. It also includes heart health, autoimmune health, brain health, mind health, mental health, bone health, right? So when we talk about women's health and well-being, it's a web of interconnected influences that actually captures the understanding of women. So one of the important aspect is about understanding women's health from physical, mental, and social perspective and having a holistic view, meaning that acknowledging that women's health is shaped by across the lifespan perspectives, from childhood through adolescence, through reproductive years, through pregnancy, menopause, midlife, and older age. So each stage presents unique vulnerabilities and health outcomes and health concerns. For example, a teenager girl navigating depression and anxiety or body image will have different needs than a postmenopausal woman managing chronic illness or social isolation, right? So another way of understanding is that if we need to go even further to have the nuance of the social determinants of health, that women's health is a multidimensional construct that is shaped by biological, psychological, and cultural determinants. So for example, low-income women may delay seeking medical help due to cost or caregiving responsibilities. Racialized women may face discrimination at health healthcare system. And immigrant women may encounter language and cultural barriers that affect both mental and physical outcomes. So as I said, it's a web of interconnected influences. So it's not just happening inside the body, but what's happening around the person in their relationships, commitment, communities, and environments. And understanding this complexity is key to designing better, more responsive, and equitable healthcare intervention for women. So what are some of the key challenges, that needs our attention and then that are still impacting women's health today? So first and foremost is the gender bias in care and research. Historically, medical research has excluded women, or they have been underrepresented in, let's say, in clinical trials, or even when they were included, the data have not always been analyzed by sex or gender. So this has led to knowledge gaps, meaning women's symptoms can be misunderstood, misdiagnosed, or overlooked together. But nowadays, the new funding agencies, and we know the CIHR and, SHRC and our federal agencies, they ask for a particular sex and gender-based lens, which stimulates most researchers to pay their attention to this important aspect. The second is the undiagnosed and untreated conditions. So it has been witnessed that conditions like chronic pain, heart disease, and mental health issues are often dismissed in women. For example, women experiencing heart problems or heart attack often report being told that it has been because of anxiety, or maybe, delaying critical treatment. So that's another thing that has been overlooked sometimes. And finally, inequities that go beyond gender. So racialized women, low-income women, women with disabilities often face multiple layers of discrimination, both within the healthcare system and in society at large. So these intersecting factors create real barriers to accessing quality, respectful, and timely care. So while progress has been made, there is still significant work that's needed to ensure equity and inclusion in women's health. Now, our understanding of women's health requires greater clarity, namely that women are not a homogeneous group. So this recognition goes beyond biology, right, and affirms that women's experiences, identities, and healthcare needs are shaped by a wide range of intersecting factors, including age, culture, ethnicity, gender identity, marital status, education, income, and life history. And without tailored and equity-focused approaches, we risk reinforcing existing disparities instead of addressing them. A one-size-fits-all model in women's health not only overlooks these complexity, it can deepen, marginalize, and reduce the effectiveness of care and support. So I think this is one of the important things that I have learned across the time, or over the time, in my work in women's health and especially women's mental health. Since I joined my master's and did my first, thesis and research work in women's mental health, I think over the years I've learned that women are not a homogeneous group. This diversity, comes from gender identity. Even trans women who, like cisgender women, face gendered health disparities and also encounter additional barriers due to, transphobia, stigma, systemic exclusion from women's health spaces. So what's next? We need strategies to address these gaps. We need customized interventions that are gender and trauma-informed, culturally safe, and participatory and community-driven in nature. Interventions that reflect women's realities. Example, safe spaces for trauma survivors, culturally competent care for Indigenous and racialized women, co-design programs. Those that are shaped with and by women tend to be more relevant and effective. We need innovation. We need integration, right, including digital and hybrid care model. We know the power of technology these days, but we have to be mindful that these digital and hybrid care models address the digital divides to ensure we are not inadvertently widening health disparities. We need integrated care models. So for example, screening for depression and anxiety during OBGYN visits or routine primary care appointments can normalize mental health conversations and reduce stigma. So these models also improve, I think, coordination between providers, this is essential for managing complex or chronic conditions more effectively. We also need integration of peer workers or patient partners or people with lived experience, perspectives that our women partners bring traditional providers cannot. And this is, again, some of my work from Canadian context. I have really learned because my earlier work was from Pakistan, so I had that clarity in mind. But when I started my projects here, I think this understanding resonates with the universal understanding of working with women, that their involvement in research and in designing the solutions and initiatives is very, very crucial. We need to also think about the women's and communities' empowerment through participatory and community-driven initiatives with shared leadership and with the concept of empowerment and co-lead, where women partners are not only the recipients, but they are the equal decision makers and the shared leaders in designing the solution for their problems. And finally, we need a change at policy and systems level. We need policy that centers women. We need research funding that's dedicated to women's health issues and well-being. And we need to pay special attention to health professionals, training to unlearn biases and recognize the gender dimension of health. So I will now briefly talk about my program of research and the example that I promised you to share from my work that you must have seen in today's posting for the nursing round. But I'd quickly give you a quick overview of the work that I do. So my program of research is equity-oriented and deeply rooted in community-based participatory approaches focused on mental health promotion and of people who experience marginalization and face socioeconomic challenges. So one of the key focuses of my work is to understand what factors and interventions can enhance the capacity of individuals, families, and communities to take control over their own mental health and support others' well-being. And my work mainly so far is focusing on women and youth. So the example that I would like to share with you all, this project was called Co-Design of an Empowerment Toolkit. And that was a collaborative study to promote maternal mental well-being and mental health. This is the research team that was behind this important work. Dr. Annette Brown, Dr. Sarah, Dov Fletcher, Jacqueline Dennison, Aki and Salima. These were the trainees from School of Public Health and Faculty of Medicine. Mamas for Mamas was the community partner, and I'm not sure how many of you are familiar with this organization. So this is a national charitable organization that support mothers, women, and caregivers in crisis by providing ongoing support to them, to the individuals and families who face poverty-related struggles, including mental health concerns. And this project was funded by UBC Health Innovation Funding Investment Awards. And I can see Shams here in the audience. So Shams was one of the graduate research assistant in this program, has played a crucial role in that. So why did we conduct this study? So I would like to start by sharing a quick background on this topic. So as we know, the psychological issues among women in Canada is concerning. In Canada, the frequency and the risk of depression and anxiety, particularly in women, have been reported twice as high as men, and women reportedly experience more barriers in accessing required healthcare, which contribute to increased treatment gap. And treatment gap, I hope we understand, is the care or the support or the help that people need, and they don't get it timely. So women in Canada also report higher rates of self-harm and suicide attempts, and COVID-19, we know, has intensified these challenges for the mental health of women living in vulnerable conditions. As I discussed earlier, that often our existing biomedical models of care ignore or overlook other opportunities of mental health promotion that is focusing on psychosocial aspects. Therefore, women who live in experiencing, intersecting marginalization and social inequities, pharmacological and psychosocial interventions alone have proved to be insufficient or ineffective for improving their lives. Empowerment has been shown to play a key role in supporting overall mental and physical well-being of people, and empowerment of women particularly has been correlated with numerous favorable health outcomes for women and their children, including mental health outcomes as reduction in depression and stress symptoms. However, there is limited research available on the impact of women empowerment on positive mental well-being. For example, women's functioning, resilience, and self-efficacy as examples. So using a community-based participatory approach and by engaging a diverse group of women, our study aimed to collectively develop an empowerment toolkit so women could better manage their life challenges and improve their own and children's mental well-being. I'll be using the terms mother and women interchangeably from now onwards, which refer to individuals who self-identify as women and who had children or are the primary caregivers of their children. So using a community-based participatory approach and in collaboration with our partner community organization, we recruited a diverse group of 12 mothers or women from BC. And these participants were women of 19 years of age or older, having at least one child. They were living in British Columbia, and they were able to understand the consent process. Three 90-minute virtual focus group discussions were conducted via Zoom. The first two focus group discussions were used to develop the content of the empowerment toolkit, while the third round was conducted to seek participants' feedback on the toolkit content, relevance, usability, and feasibility. Each focus group discussion was conducted using a separate semi-structured discussion guide, which were developed in consultation with our partner community organization. As you can see on your screen, we also conducted a comprehensive literature review of empowerment skills. And the reason for doing that was we also wanted to include some evidence-based strategies and skills that have been tested or that are in place or in use for women's mental health and mental well-being. So what we did was we prepared a plain language summary of the literature, and we brought that summary in our second round of focus group discussion to our women. And our women, we had like breakout rooms, small breakout rooms with one facilitator in each group. And then women thoroughly went through the list of the skills that were shared with them, and they provided their feedback, like which strategies or skills they wanted to see, or maybe they see more meaningful and to be included in the toolkit. And they also provided feedback in maybe XYZ skills that are not very useful, and some of the skills that were not there in that list. So this was a good exercise to have their input on the evidence-based skills and then integrating their own skills that they have identified in focus group discussion 1. The third round of the focus group discussion, between focus group discussion 2 and 3, we prepared a draft of the toolkit, and we took that draft in the third focus group. And then women provided, again, through the small breakout discussion, we went through all the modules that we prepared, and women provided their feedback through a quantitative checklist, which was anonymous, and through their subjective input that was provided during the focus group discussion. So this was the demographic characteristics of the participants. The mean age of the participants was about 35 years, ranging from 27 to 46 years. All participants had children. Our women's group was coming from both urban and rural settings. Women represented a diverse ethnic background. We had indigenous representation, white women, Latin American, South Asian, and East Asian women. Most of the women had completed their undergrad and grad education, and about 33% of them were working either part-time or full-time. So these were the skills, or the list of skills that we came up after integrating women's insights and their approval of evidence-based skills. So there were total 10 modules that were included. And as you can see on your screen, the first module was about the understanding of mental well-being and empowerment, which was not there at all in the literature skill set of skills. And then women really recommended to be it as a first module in the toolkit. Social support and building networks, self-care, emotional regulation skills, self-efficacy, building and maintaining family dynamics, parenting skills, financial skills and money management, advocacy skills, and work and life balance. So each module was of the toolkit was organized with a consistent format. ranging in length from 90 to 120 minutes. And the modules included a brief background, objectives, time duration for each session, a mix of interactive activities such as discussion prompts, case scenarios, self-reflection exercises, and each module concludes with a self-evaluation component. So this interactive approach was designed to encourage active participation while offering flexibility for implementation of this toolkit in community or individual setting. So as per the findings of a third focus group discussion, which was mainly for the feedback, the toolkit was very well received by our women participants. Women appreciated particularly the engaging content, interactive activities, especially role plays and cases representing different cultures. They also appreciated the opportunity to learn new skills through this toolkit, and they recommended the need for facilitated online sessions because some of our women participants were coming from rural setting from northern BC, and they said like for in-person session, it really gets hard for commute, and especially people who are living in lower mainland, for them to commuting and childcare was one of the concerns. So they recommended to have facilitated virtual sessions for this toolkit. So in conclusion, we believe that the uniqueness of this toolkit is that it's women-driven in nature, and we have also used the evidence-based resources, which increases its potential to enhance women's ability to take a better control over their lives and support the mental well-being of women and their children. So now as next steps, we are applying for funding for its pilot testing and to conduct an effectiveness trial. So thank you very much. I'll stop here and I'll hand it over to Ruby Dave to continue with this presentation.
Thank you, Saima, for taking care of mental health of women. So I'm going to switch a gear to their physical health now, and more specifically talking about their cardiovascular health. So I am going to talk about my program of research, which is mainly about optimizing cardiovascular health of postpartum women. And I will present some of the work done, but mainly why and how I'm going to implement this work. So again, I would like to start with the land acknowledgement. I acknowledge that UBC Vancouver is located on the traditional, ancestral, and unceded territory of the Musqueam people, and the land it is situated on has always been a place of learning for the Musqueam, who for millennia have passed on their culture, history, and traditions from one generation to the next on this site. So talking about burden of cardiovascular disease, we all know that the burden of cardiovascular disease globally is in rise, and it has become one of the leading cause of death globally. When we see the statistics, cardiovascular disease-related deaths had jumped globally from 12.1 million in 1990 to 20.5 million in 2021. And the current statistics shows it's rising more. The trend is increasing. It's predicted that CVD is going to be responsible for more than 22 million deaths by the year 2030. However, most of these cardiovascular related disease or deaths that are preventable, and it said that evidence suggests that almost 80% of premature heart attacks and strokes can be prevented. So when we see trends in cardiovascular disease, and this data or graph is obtained from World Heart Observatory, and the most recent is until 2019, but trend is similar even if we see the 2024 data. So the one that's in red represents the global prevalence. The one that's in green is for males, and the one that's in blue is for females. So we can see overall the rate, the health rate in female is higher as above average and also higher compared to males. And this is the same thing that I'm presenting in numbers. So if we see the cardiovascular disease in female, their prevalence, and it's represented in rate per 100,000. So it's almost not double, but it's higher compared to global average or even compared to male, and it's increasing in women. So talking about heart health, so why women's heart health? The reason I'm more interested in women's heart health, I'm a women's health researcher, but more interested in their heart health is because of its rise in nature in women, and there are some specific female specific risk factors that makes them at greater risk. So traditionally, or in the past, heart disease was considered as a man's disease, but it's no longer only considered as man's disease. So while heart disease is in decline in most of the men, it seems to be rising among women. And the statistics shows that it has become the #1 killer of women worldwide and is also the leading cause of premature death in women in Canada. And if we say in number, it's almost causing 1 in 3 deaths each year. So there are many men-centric models that talk about all those traditional risk factors. So for example, smoking status, obesity, diabetes. Even though women are non-smokers and they don't have all those traditional risk factors, even still heart failure or stroke kind of things are seen more in women. So definitely we can think of that all those male-centric models that has been used for so long is not working and is not giving us the true story of all those risk factors that's related to all those cardiovascular disease in case of women. So burden of CVD in women, almost 35% of all deaths in women and worldwide are caused by cardiovascular disease. And in number, it represents 275 million women diagnosed with CVD in 2019. So that's from the Lancet. And there are, as I said, these numbers are rising day by day. So when it comes to cardiovascular disease in women, so the risk starts from their early age and it goes until their postmenopause or even in the later age. So when we talk about their lifespan risk, it starts mainly during their adolescence, where we start thinking about if mainly the genetic risk. So if someone's parents has that heart disease, the children is at increased risk of having CVD. Then comes the young adult phase, where it's a phase of having a menstruation cycle in the life of female. So early age of menstruation, and when it's under 12 years of age, or we say early menarche, it's linked to higher risk of heart disease in later in their life period. Similarly goes to polycystic ovarian syndrome, which is a hormonal that impacts hormone of a female body, and that's also again linked with higher risk of cardiovascular disease later in their life. Then it comes a pregnancy, which is a stress test for any women's, and that pregnancy changes so many brings so many metabolic or vascular changes in the body. And again, it's the time of pregnancy where some women experience adverse pregnancy outcomes. And I'm going to talk about adverse pregnancy outcomes more in detail, but all those adverse pregnancy outcomes, so for example, hypertension that develops at the time of pregnancy, or diabetes that develops at the time of pregnancy. So any women experiencing those adverse pregnancy outcomes are at increased risk of cardiovascular disease later in their life. And those risks are considered to be happening as early as in their first decade of postpartum period. So within 10 years of delivering their baby. And there has been a myth that all the pregnancy-related complications go away, but that's not the case. Some of them stays with the women, and which are considered to be the CVD risk factors. And then comes the postmenopausal period, which is again one of the CVD risks for women, in which it alters the cholesterol level of women body. So my program of research is mainly about optimizing the cardiovascular health of postpartum women with those reproductive and pregnancy-related risk factors that are not actually assessed during their postpartum period. So I said why women, but now why postpartum heart health? Because I already discussed about all those risks that's associated with pregnancy-related adverse pregnancy outcomes. And pregnancy is essentially a stress test. And some of the women, as I mentioned, and if we talk about prevalence, it's almost 10 to 20% of women experience that adverse pregnancy outcomes. And all those adverse pregnancy outcomes are actually cardiovascular disease risk factors that arise from all those metabolic and vascular changes that happens during pregnancy. And of course, this prevalence varies by different race and ethnicity, but I'm not presenting those values based on race and ethnicity in this presentation. So all those adverse pregnancy related outcomes, all of those are considered as CVD risk factors, and that place postpartum women at a higher risk of developing CVD sometime in their life. And these are some of the adverse pregnancy outcomes. So gestational diabetes that can happen at the time of pregnancy. So any degree of glucose intolerance with its onset or first recognition during pregnancy. The another one is gestational hypertension, and the definition for this is any new onset of hypertension. So this is separate from the chronic hypertension that some people may have before their pre-pregnancy period, and that can continue. So this is the hypertension that's newly originated at the time of pregnancy, mainly after 20 weeks of pregnancy, but this is without proteinuria. Then comes the preeclampsia, which is again new onset of hypertension that develops after 20 weeks of pregnancy, but now it comes with proteinuria. So protein is seen in urine tests, and then it's also some of the evidence of end organ dysfunction. Preterm delivery is another adverse pregnancy outcome, which is considered to be any delivery before 37 week gestational age, and it can be regardless of any cause. And finally, the small for gestational age. So any babies who are born with birth weight below the 10th percentile for their gestational age. So these are some of the examples of adverse pregnancy outcomes. And this is one of the study that synthesized all those relative risk and odds ratio of what's the risk, how much is the risk among women with all these. So in the left column, you would see all those adverse pregnancy outcomes, and then there are a number of increased risk, and we can see almost in average 2 to 4-fold risk among women of all those cardiovascular related disease or ischemic heart disease or stroke or heart failure, which are all considered as a composite cardiovascular disease based on if they have experienced any of those adverse pregnancy outcomes compared to the women who did not experience any of those in their pregnancy. So studies suggest, and there is an evidence that all these adverse pregnancy outcomes do impact long-term cardiovascular disease risk in women. So one of the most recent study that was conducted by University of Ottawa Heart Institute, and this is published in 2025. So this is the most recent that followed almost over 770,000 women. And the result of this study showed that women who experienced hypertensive disorder of pregnancy were associated with 45% increased risk of developing atrial fibrillation, which is one of the CVD. And the risk was as early as 7 years postpartum, so within their first decade of delivering their baby. And of course, this risk amplified if it was recurrent. So if someone has recurrent preeclampsia or eclampsia, the risk keeps doubling or escalating. So the findings and the conclusion of this study was there is a crucial need to include those obstetric history that's mainly not asked for or not assessed for in postpartum women for their cardiovascular risk. And this needs to be included in a prediction tools that we use for women. This is another study that conducted a systematic review and a meta-analysis and examined preeclampsia and future CVD risk. So again, preeclampsia is one of the CVD risk. So the results suggested that preeclampsia was associated with a 4-fold increased risk of incident heart failure and a 2-fold increased risk of coronary heart disease in women. Again, highlighting the importance of monitoring CVD risk factors in women with a history of preeclampsia, but not only with a history of preeclampsia, but with history of any kind of adverse pregnancy outcomes. So We do talk about follow-up and asking for all these screening questions in women, but there are gaps that still exist. So whenever a woman, and it's also based on my own personal experience during my postpartum phase. So when we encounter any primary healthcare setting or any healthcare setting, so the most commonly question that's asked to anyone is if they have any family history or not, or if they smoke or not, which is important because these are traditional risk factors. And when I'm talking about female specific risk factors, it's not that traditional risk factors are not there. So traditional risk factors are there, but on top of that, women experience those female specific risk factors, which can be related to their pregnancy or any reproductive features. So the questions that's not asked, or I would say rarely asked, is have you ever had pregnancy complications? So this is something that needs to be assessed in any postpartum women, and mainly in women who experience any of those risks. And we are not going to know if whether or not they are going to they had experienced any of those risks without asking or incorporating that in our risk assessment. So one of the way to overcome the gap is to incorporate those assessments and include those reproductive and pregnancy related risk factors in the CVD risk assessment of women. Talking about tools, when I said risk assessment, of course, we do those history taking and asking women, but there are several cardiovascular disease risk assessment or risk prediction tools that's available. So the question comes here, if it's available, then why do we need another tool? And the answer is all these tools are mainly either male-centric. So most commonly that we hear is about Framingham risk score, which is still used in Canada and also used in risk assessment of women, so which is male-centric. But then there are other female-centric tools. So for example, CARPREG-2, modified WHO classification, or ROPAC, or CUREX-3. However, the issue with this tool is either they predict risks only within 6 months, or some of the tools are used for women who already have those congenital heart disease. So it's not predicting the other future CVD risks beyond 6 months or beyond that can happen in that first decade of their life. And none of the existing, and one of the major limitation, none of the existing tools take into account any of those reproductive or pregnancy related risk factors of cardiovascular disease, which needs to be assessed in women, mainly postpartum women. So I see there is an opportunity to develop a CVD risk assessment tool, which is my program of research is mainly about. So this gives an opportunity for us to identify women at higher postpartum cardiovascular disease risk and support any primary healthcare providers, because it's the primary healthcare setting where women go for their first, where they encounter, until and unless it's an emergency, so they encounter their healthcare provider. So the goal is to have this tool to be incorporated in the electronic medical record used in the primary healthcare provider, where they can assess those CVD risks in postpartum women, and which will allow providers to identify those unique cardiovascular health needs in women and then provide them tailored intervention based on their needs. So my program of research mainly is guided by this cardio-obstetric model of care. So I have adapted this model because it was again mainly used in women with congenital heart disease, but this can be adapted. So in context of my research. And one of the feature that it talks about is following women or taking care of women throughout their pregnancy journey. So preconception, pregnancy, during their delivery, postpartum, fourth trimester, or long term. And my program of research is mainly about long-term risks. So if they had any of those APOs or adverse pregnancy outcomes, so the requirement of CVD risk screening to identify any of their long-term CVD risk and providing that tailored intervention so as to prevent that risk, their long-term risk. So my research is about prediction research, which has mainly 3 components. The first is about finding those predictors, which I have completed, and I'm not sharing the manuscript now because it's under preparation phase. But all those risk factors of those APAs, adverse pregnancy outcomes, and also those are, we also found the similar risk in synthesizing the literature. So that part is complete. So the next step is the prediction model study. So I'm currently working towards applying for funding or using some of my funds through UBC to develop and validate a model. So before developing or validating, we need a database actually that represents the so I'm interested in doing this in the Canadian context. So I'm currently heavily working in accessing the national database and linking it to the administrative database so as to cover as many variables required for this development of model, but also validating it so that it can be actually used in the clinical setting. And finally, there will be the prediction model impact study, but that's the future phase of my work. So all of this research gives provides us an opportunities to improve cardiovascular health in postpartum period. And American Heart Association has actually suggested the 8 essentials of life. So as we can see in this figure, so actually maintaining those healthy diet, maintaining our lipid level, no use of nicotine, having a good sleep, maintaining our lipid level, maintaining our blood pressure, maintaining our sugar level, everything that can actually help us prevent. And all of these are behavioral part. And of course, on top of this, there are those prescriptions or medical management that provider can suggest to any women depending on what their need is and how it can be tailored to meet their unique need. So I will end my presentation here and I will open the floor for questions and discussions for both of us.
Thank you very much, Dr. Hirani and Dr. Dev. That was a really fascinating presentation from both of you. And thank you to our audience for coming along and your questions and discussion. And hopefully we will see you at the next nursing rounds. Have a good afternoon.